It's starting. All right. So, hello everyone. Good evening, good afternoon, good morning. Thank you for joining us today. My name is Charlie Sitongjang. I am the president of CGHI, the Coalition for Global Health Innovation. We are a group of a nonprofit, youth-led, all volunteers. We're from 6 different continents. We have a community of more than 100 members. We're from different disciplines related to and or in global health and international development. Our goal is to help young professionals to be the change makers, and we want to advocate for equity and inclusion in global health. And we organize webinars like this one and online events where we center the voices of young professionals and senior professionals with a focus on health equity. And we also publish articles and blogs on our website. And we also have our pre-incubator where we help young professionals to build their projects, connecting them with advisors, connecting them with opportunities, international conferences. And we also, every 2 weeks, we have our community call where everyone can join and we network, we share what we're working on, and we brainstorm what we can do together. So I invite everyone to get in touch with us. Yeah. And I want to introduce our Vice President, Yelena. Do you want to say something more about the coalition?
Thank you, Charlie. Well, I think that you did a very nice job with introducing what we do. I can only welcome everyone to this webinar. We are very fortunate and very excited to host it, and we hope that you enjoy it, you'll learn something new, and we definitely encourage all of you to ask your questions throughout the webinar. I will also be sharing some links about like how you can connect with us. So feel free to drop your questions in the chat throughout the webinar, and then when we finish all of the presentations, we can discuss, but that is the information that is later to come. Charlie, back to you.
Thank you, Yelena. So yeah, thank you everyone for joining us today. So today we are talking about the universal health coverage, which is one of the major goals for WHO and also just for any global health professionals. And today we are focusing on South Africa. South Africa is a very special case because of the complicated history. So first I want to introduce our moderator for today, Tessa Klaas. Tessa Klaas is an MA Development Studies candidate at the University of Johannesburg. She has a focus on health diplomacy during the pandemics. Her research examines the diplomatic relationship between Cuba and South Africa and how it shaped their response to COVID-19. Which highlights the opportunities for the Global South to enhance pandemic preparedness through strategic health diplomacy. And now I want to invite Tessa Klaas to tell us more about today's webinar and also our speaker. Over to you, Tessa.
Thank you, Charlie, for the warm welcome. So excited to join you all in discussing South Africa and learning from all of you what universal health coverage means to you all and in achieving that in your various states. My name is Tessa Klaas, and today I'll be the discussant for today's webinar that is hosted by CGHI. I joined CGHI in September as the community officer. So the focus of today's webinar will explore the pivotal topic in South Africa's journey towards equitable healthcare, the politics of national health insurance policy, and its implications for universal health coverage. South Africa's healthcare system has grappled with disparities between public and private sectors, affecting millions who are waiting to receive care. The focus of today's talk, which will be the focus of today's talk, it is an honor to welcome Dr. Sibuyisiwe Wonci. who is a postdoctoral research fellow at the Institute of Pan-African Thought and Conversation at the University of Johannesburg. Her postdoctoral research project locates the National Health Insurance Pilot Program in South Africa within the contested terrain of health policy experiments in Africa. Siwe holds a PhD in sociology from the Social Policy DST NRF SARCHI Chair at the University of South Africa. In 2015, she obtained her master's in public health from Montclair State University in New Jersey under the Fulbright Scholarship. She also holds a bachelor's degree and honors degree in sociology from the University of Western Cape. Her research interests are health systems, strengthening, health policy, universal health coverage, gendered health systems, reproductive health, feminism, and Black studies. Without further ado, let's welcome Dr. Siwe Wonci, our keynote speaker for tonight's webinar, to delve into the dynamics of the national health insurance policy in South Africa. Thank you, Dr.
Thank you so much for that warm welcome. Welcome everyone. I understand we are in different time zones in different parts of the world. Thank you for gracing this event. And I just want to highlight that this particular webinar is dedicated to the people of Lebanon and the people of Gaza who are under siege by the Israel's intent genocide. This is dedicated to the healthcare workers in Gaza right now at this moment, particularly in North Gaza, who are being bombed, and to the women and the children who are mainly trying to survive. Today's talk is titled Waiting to Receive Care, the Politics of the National Health Insurance Policy in South Africa. But before we start to talk about this particular historic moment and historic bill in the South African context, I just want to lay down the kind of geography of our healthcare system in South Africa. So the first democratic election in 1994 marked the collapse of the apartheid government in South Africa. However, the efforts to create an equitable healthcare system for all, in which people have access to quality life-saving healthcare services, has fell short, or some could confidently say it has failed, because of the two systems which exist parallel together, which is the private healthcare system and the public health sector in South Africa. So South Africa's healthcare system has these two pillars which are really driving them. And so it's important to understand that the expenditure on healthcare in private and public health sectors in South Africa is roughly the same. However, the inequalities lie on the numbers covered by each sector. In 2019, the South African government spent 9.11% of its gross domestic product on healthcare. We are among the countries who are spending a lot of money on healthcare services. And in monetary terms, this amounts to 56.9 plus minus billion rands. However, if you're looking at this gross domestic product, it's divided between the private health sector, which serves only 14% of the population, and the public health sector, which only serves 82% of the population. And the 40% of this population constitute the Black, which we call the Black middle class, who can afford medical aid because of the nature of their employment. and the historically advantaged groups in South Africa, which are predominantly white households. Your coloreds features in there, and also your Indians features in there. However, the 84% of the population, the majority of them, remains to be the black households, colored, and some Indian households. So the two-tiered healthcare system in South Africa, within the private, the private healthcare sector serves, which remains to serve 40% of the population. The population who's covered there enjoy the financial and human resources of this country, which are concentrated in the private healthcare sector. Then the 5% of the population is left to rely on an underfunded public health sector, which carries tremendous disease burden with insufficient financial and human resources for health. So that's just kind of like the layout of our healthcare system. And the racial inequalities here, the high number of households covered under medical schemes that have access to private healthcare services are white households. 72% of the private people who are covered in private healthcare are white households. 52% are Indian Asian households. 17% are colored households, and only 9% are in the black households. So this shows you the kind of racialization within these inequalities, which really speaks into the tragedy of the apartheid system and how it used to classify people and give them certain economic privileges according to that. The health expenditures in South Africa, scholars have complained, is the same as in middle-income countries. However, the financial resources are not distributed evenly between the private and the public health sector, thus deepening the kind of health inequalities. The challenges of the private health sector, of course, there are challenges within the private health sector. It's not on high technology, everything, hotel, looking like gloom. This particular sector is expensive and excludes the poor working South Africans, right? So for example, a person who works in Pick n Pay, which is a food industry, or ShopRite, does not even qualify by their kind of like income strata to have a medical aid in this country. The private health sector is also characterized by fee for service. When you go see the doctor in the private health sector, you're going to pay for the earbud, you're going to pay for the bandage, you're going to pay for the needle, anything that is being used on your body, you will pay. And this results in a high cost of medical services provided in the private health sector. And the medical aid, people who are in medical aid in South Africa will tell you that by this time of the year, all of them, their funds have been exhausted. So people then resort to using their disposable income for healthcare services. By August, going into December, nobody has savings in their medical scheme because of how expensive the sector is, driven by the fee for service kind of costing. And so the failure of the public healthcare system, which I'll talk about also here, also leads to a lot of households just going to pay out of pocket for what? For medical healthcare services. And in 2016, and this might have doubled over the years, it was estimated that South Africans spend close to 29 billion rands in out-of-pocket expenditures. In 2020, this amount increased into 32 billion rands, just people coughing money out of pocket to pay for healthcare services. And so also there are fragmentation in terms of pools of funding in the private sector. So one would expect that the private sector has this big one medical aid in which people contribute into it so that the risk can be shared among the private health sector population. But this is not the case. We've got so many medical schemes in South Africa, and that means that the idea within health insurance of cross-subsidization and redistributing risk becomes minimal. Even in a single scheme, you've got certain tier which are much more for much more rich people. For the executive, they've got their own tier and their own benefits. So the higher you pay, the more benefits you have. The lower people also have got less benefits. So there's really fragmentation in this in this sector. And the challenges of the public health sector. So and we will still remain here in terms of the financing of the public health sector. So the global fund, which you call the global fund from for healthcare services in South Africa, is generated from the national revenue annually, right? And it is divided into 3 government streams: national, provincial, and district level. And district level and municipality are much more responsible for your sanitation, for your environmental health, and all of that. However, it's very important to note that the fiscal federalism, which was adopted in 1997, has resulted in the National Department of Health, national level, having less and less powers in deciding how the global fund should be spent by provincial governments. So the people who have a lot of power in purchasing healthcare services for the population, for the public health sector, are within the provincial government. So we've got 9 provinces, and each province decide on how much it will spend on healthcare. So the government, the national government, gives money to the province, and the province decide, right? Then the different departments at the provincial level, such as education, health, or anything that is designated at the provincial government, battles for this funding. And most of the time, education and health is much more underfunded. And in 2021, and 2022 financial year, it is estimated that budget for health was 64 billion rands in South Africa. And 86% of this budget, which is 55 billion, was transferred to provincial government. So Western Cape decides what it wants to do, Gauteng decides what it wants to do in terms of spending within the public health sector. And again, this has to do with how the country's administration in the apartheid era was divided. And so the power of purchasing the public healthcare services in South Africa lies within the provincial government. It does not lie on national. National can provide guidance, but it lies within the provincial government. Each province has its own service providers, right, that they contract. And again, the cross-subsidization between the well-off provinces such as Western Cape, Gauteng, KwaZulu-Natal, compared to the rural mainly provinces, you can see then there are certain differences there. And so that is kind of like how the public financing is done in terms of healthcare. Besides this, the public health sector in South Africa is characterized by long hours of waiting to receive care, lack of proper sanitation, lack of safety and security for healthcare workers and patients, drug stockouts at times, and then also bad attitude of healthcare workers. And then I always say to people, it's not that they have bad attitude, it's just that they are overworked and under stressed. But we can have that conversation. The burden of disease here, we still battle. It's become very manageable. TB and HIV, maternal and infant mortality remain to be our issues in South Africa. Road accidents remain to be our issues. Interpersonal violence, chronic illnesses such as diabetes and hypertension continue to put a strain. Shortages and maldistribution of health professionals in the public health sector is an issue, and they remain to be much more concentrated in the private health sector. Health professionals in the public health system feel exhausted and sometimes disempowered because they work long hours to provide healthcare services to a high number of patients. So in a public system, meaning a public healthcare system, especially in the urban areas where people are much more concentrated in high numbers, one doctor can be seeing close to 100 patients or even 150 patients just a day, right? And this can be also an underestimation depending on where you are. Health professionals are more likely to work in urban areas than in rural areas. So the rural areas, provinces are struggling because people don't see the incentives as to why they should go and work in rural areas. Lack of good schools for their children are some of the issues, and incentives for the government for them to move. So then there's also an urban and rural divide in which the rural areas remain not to have efficient healthcare, quality healthcare services. I just ask for a moment because I'm seeing it's getting dark. I just need to turn on my light and I'm coming back now.
Hi, everyone. I just want to say that please feel free to share in the chat box here where you're from, where you're joining us from, and your name on what you do. And also feel free to invite your colleagues to join our webinar. Thank you. Back to you, Doctor.
Thank you for those patients. It's getting dark, so I needed to put my lights on. And then to respond to the challenges of the healthcare system, the Ministry of Health introduced the National Health Insurance Policy through a green paper which was published in 2011, and the National Health Insurance White Paper which was introduced in 2015. It's very important to note that the resolution of the National Health Insurance was spearheaded and led by the African National Congress. The African National Congress was in power for 30 years in South Africa, and they lost the majority of power with 10% this year. They are regarded as our liberation movement and the armed struggle. And most of you know Nelson Mandela. Nelson Mandela was an ANC comrade, and then this National Health Insurance became part of the I'll remember the conference resolution that took place. I think it was in Limpopo, but I think I have it on his history. And so here, that resolution of the conference said that South Africa needs to move towards universal health coverage, and ANC was in power then, and they introduced this into Parliament. The white paper defines the National Health Insurance as a health financing system designed to pool funds. These are going to be very important as they set out the kind of the contestation. Designed to pool funds and purchase healthcare services on behalf of the population. The policy promises to promote social solidarity by ensuring that the health financial resources in the country are redistributed equally across socio-economic groups to save lives, to improve health indicators of the population, and to protect the population from the financial burdens of healthcare costs. It is estimated that the National Health Insurance Policy, which cost South Africa 256 billion in the year 2025 and 2026, and we are in next year. However, the political game has changed, and we'll talk more about that. The projected figures of the National Health Insurance Policy have been criticized as optimistic and underestimating the high cost of administration. However, scholars such as Minkainte have warned that this criticism of NHI, that NHI will cost the country more money, is a lie, because already South Africa is spending close to 500 and something billion on healthcare. So, for example, in 2020, South Africa spent 569 billion rands on healthcare, which is double what the NHI will cost. So there are those contestations. However, I just want to spend a bit of time before I go into the history. I don't know where the slide is. Okay, I think it will come together. I'm just worried for no reason. Okay. So the history of the National Health Insurance in South Africa is a very long one. Not the National Health Insurance, the history of universal health coverage in this country is a long one. One of the most referenced health policies of the 21st century, where South Africa was thinking about moving towards universal health coverage. It was I think.
Can we make sure everyone's muted?
Yeah. So it was the one most reference health policies. It is known as the National Health Service Commission, also known as the Gluckman Commission, which was led by the apartheid government. And this is very important for us because the apartheid government was very central in wanting to address the issue of the poor white. So if you're looking at the Carnegie report, that post the Anglo and Boer War, there was a crisis of poor white people in South Africa. And the South African apartheid government at the time had to intervene by social welfare policies such as grants, such as making sure that there's public healthcare systems. And actually, during the apartheid, much more of the healthcare system in South Africa was public health system. It's just that it was racialized. There was healthcare system for Black people and healthcare system for white people, which was top of the world. It was now in the 1970s when the apartheid knew that they were going to lose the struggle, then they started privatizing our healthcare system. So if you look at our historical records, South Africa's healthcare system has been heavily public historically. So this Gluckman Commission comes and it proposes a national health service that will provide healthcare services to all South Africans. Gluckman, of course, was a white man, but who was thinking ahead in terms of these were the healthcare workers who were dealing with the issues of healthcare services of people on the ground. And they realized that whether you are white or Black, Asian, green, TB affected you the same way, right? The only aspect of the Gluckman Commission that was not that was implemented is it was actually rejected as a much more revolutionarized health policy, where now we're going to give healthcare services to Black people. And the only aspect of that policy the apartheid government implemented was to build 44 health centers across the country for public health system. And any other thing, they said this is not going to work. It means you are bringing Black people and white people together in the same healthcare system. As an apartheid government, we're against that. Unfortunately, all the other recommendations were not. Throughout the history of the ANC, African National Congress, as a reminder to those who are just gone, who were central into becoming the liberation movement of South Africa, they have been active in their policy documents in proposing universal health coverage. The annual conference of the ANC, which took place in 14 November 1943 in Bloemfontein, formed part of the African claims, and they claim that we need universal health coverage in South Africa to address the health inequalities. The Freedom Charter, which was adopted by the Congress of the People on the June 5th, 1955, Cape Town, which remains to be a historical document, which the Constitution we reference to and the Bill of Rights says that a preventative health scheme for all must be run by the state. The ANC's conference in 1990 in Maputo also discussed the ANC's National Health Plan, which planned to address the health inequality. So there's a long history of this country of universal health coverage. The current National Health Insurance Policy actually was adopted on the African National Congress 52nd Conference in Pulukana, Limpopo on December 16, 2007. Post-1994, there were a lot of proposals for universal health coverage, right? The Commission on Old Age and National Health Insurance, this again was in the 1928 before our apartheid government. And of course, we looked at the Committee of Inquiry to National Health Insurance, 1935. So there were certain committees as well. The most referenced one being the Gluckman Commission. And then in 1994, the Healthcare Finance Committee also proposed that we should have a universal health coverage in South Africa, although the kind of like financing became different. Committee of Inquiry in on national health insurance in 1995, the social health insurance for the working group for the working people was proposed. Committee of Inquiry in 1997, Committee of Inquiry into a comprehensive social security for South Africa, 2002. So you can see South Africa has been thinking pre-1994 about ways to move towards universal health coverage. And now we came into this. The politics now. So my doctorate looked at the politics of the national health insurance, but particularly the National Health Pilot Program, which was supposed to test how South Africa was going to purchase healthcare services, how districts were going to buy healthcare services to see how the NHI fund will work. However, the key findings from the NHI pilot program is that what was supposed to be piloted in South Africa during the national health insurance was not piloted. What was piloted was to test primary healthcare interventions such as general contracting, GP contracting, such as ward-based outreach teams for primary healthcare, CCMDD program to deliver medication and all of that. And these had nothing to do with the national health insurance as a financing health system. What was supposed to be piloted was how the different districts were going to be given money that will resemble an NHI fund and see how they were going to be able to use those funds to purchase healthcare services from both private and public health provider as the NHI proposes. And it was the contestation between the National Treasury and the National Department of Health and their disagreements that led to a compromised pilot program. Because the National Department of Health and the National Treasury do not agree, as most South Africans, they did not agree about the financing of the national health insurance. So we see here, these are the kind of like politics they started even within the pilot program. And even what was piloted as primary healthcare interventions was underfunded to declare that the national health insurance in South Africa will not work. However, people that say that the pilot program failed, they are misled because the pilot program did not test NHI as a health financing system. They only implemented primary healthcare interventions which had nothing to do with the policy. Primary healthcare is central to the NHI, but it tells us nothing about how the government will purchase funds from private and public providers. So this becomes important. Then at the eve the National Insurance Bill, of course, was passed into Parliament. It went through the whole public participation and all of that. And scholars was published in 2019, 2023. The National Assembly passed it, and it went through also public participation. And it's very interesting that scholars say that the people that were much more against the NHI on public participation were people, majority of them were white. Also, majority of the Black people who were against it were those who are privileged to have their medical aid. However, the majority of the people on the ground said that you need to improve the healthcare services, and we believe that the NHI should work. So again, you see the kind of class differences and class politics playing into the aspect of universal health coverage. And I will not bore you here about how services are going to be purchased. We can talk about that later because I'm mindful of time as well. And so it's very important to also note that what's important here, what is the most highly contested part of the NHI bill is what we call the NHI fund. So the NHI bill says the NHI fund will be run by the chief executive officer and 11 board members who will account to the Minister of Health. The Minister of Health will be responsible for the governance and stewardship of the NHI fund. A risk and fraud prevention investigation units will be established to protect the NHI fund from corruption. As we know, in South Africa, we have issues with state-owned enterprises. When the NHI fund is established, medical scheme will continue functioning and offer people complementary healthcare services not covered by the NHI. However, people will not be allowed to opt out of paying out of the NHI fund. So the income that you get, you'll be taxed, and your income tax will be taxed, maybe 1,000 Rand to the NHI fund. And if you are working, you will not be exempted out, whether you keep your medical aid or not. And these are important issues. And so, okay, I talked about the supporters, you know, who supports. And one of the other important actors that will, and I just want to just talk about the structure of the NHI fund. I don't know why I didn't. Okay. So the structure of the NHI fund, let's just talk about the structure. The structure is going to be a public pool of funding. And this public pool is going to be, of course, be operated by the government. Is going to be function, you know, under the national, you know, health, right? Under our national. Now, people who are working are going to be taxed. So it's going to be a tax-based system. So if you are getting paid 1 billion Rand, you're probably going to be taxed, for example, okay, let's say you're going to be taxed, for example, 2,000 Rand, right? And if you're getting paid, for example, 20,000 Rand, you'll be taxed, for example, 500. This just, so what the taxation system, the higher you get, the taxation of the NHI is going to be based on how much you are earning, right? The lower you get, you're going to be taxed less because, yeah, so the income kind of tax. Also, money that was used in the private health sector, subsidies, medical aid subsidies, because the government subsidizes people for their medical aid. So these medical aid subsidies will now go into what? Will now go into the NHI fund. The government will no longer subsidize medical aid. And also kind of like national revenues, which are much more set for the budget of health, all of that will go to the NHI fund. Now, the NHI fund will then purchase healthcare services. So the state will buy healthcare services on behalf of the population. This becomes very important because it's not all the private healthcare sector that is against NHI in South Africa. Your Mediclinic is quiet, the big hospital, Netcare is quiet, all of the private, which I call them service providers, they became quiet because they know they're going to benefit from the NHI. Then the government will then accredit healthcare service providers who are coming from the public. So the public health hospital will be improved so that the NHI ready, but also the private hospitals, they can come into the party. So it will purchase healthcare services from both private and public health providers. So private people will still, that's why it's only the medical aids that are against, mostly about NHI, because they will lose their business. But most private hospitals are very quiet because they're working on the background to get ready for NHI. This becomes important into the opposition. The Psychological Society, and I'm going to wrap up now, the Psychological Society of South Africa has come out and say the NHI bill is the right step to the direction and believe it should be implemented. It will address the inequalities. The Congress of South African Trade Unions, which are unions, supports the NHI and believe it will improve the health of the working class. From the research that I did with healthcare workers, because it's important to talk to healthcare workers. GPs whom I interviewed who were in the private health sector that were much more supporting of NHI were mostly Black general practitioners who had their own practices. However, white GPs that I interviewed who had their private practices, they were more likely to be against NHI. Becomes important. General practitioners within the public health sector were also more likely to support the NHI in comparison to those that interviewed in the private sector, because these doctors were saying that we are working under these conditions and they need to be reformed. Policy makers, senior government officials at the National Department of Health were much more optimistic about the NHI. However, policymakers and senior government at the National Treasury were much more skeptical. And this brings you into the divide of the politics within the country. And critics of the NHI say that it will be another money-making scheme for the whole government to take money and politicians to steal money from it. The Democratic Alliance, which is now in a political marriage with the African National Congress and other parties, is bluntly, boldly against the NHI policy. And Private Business Association has rejected the NHI bill. What is interesting, again, big hospitals like Necare, Mediclinic are very quiet on the NHI. They have not said a thing. And scholars warn that if South Africa's national health, universal health coverage must succeed, the government must address the issue of unemployment, which remains at 34% currently, in order to have a healthy tax base that will contribute to the NHI. And these are some of the opposition of the NHI. The people who are working are feeling that we're already heavily taxed, now we're going to be taxed more. So it's important for South Africa not only to address unemployment, but to address human settlement, to address the land redistribution project of this country, to make sure that the majority of the people have dignified lives, have dignified neighborhoods, because if you fix the healthcare system without fixing other things, social determinants of health will challenge the very idea. Is the National Health Insurance Bill in South Africa another dream deferred? On May 15, 2024 at 2 p.m., President Cyril Ramaphosa signed the national bill into law after 17 years of waiting for its development. Hence, my question, who's waiting to receive care in South Africa? However, it is worth noting that the ANC lost its majority in the general elections on May 29, 2024, and is now in coalition with the Democratic Alliance, which is against the National Health Insurance Policy. And again, currently we're seeing the Democratic Alliance is the birth or grandchild of the National Party, formed after 1994. And its politics and its policies are far-fetched from the African National Congress, which is much more regarded as the Black liberation movement in our country. And the question again is, after Cyril Ramaphosa's term, the current president, is there a future for a government of national unity in South Africa when the new ANC politicians rise, whom now we've also identified very clearly in our news, the likes of your Panyaza Lusufi within the movement, or what people called the left wing of the African National Congress, can have a discussion about this. In light of this political development, again, is the National Health Insurance Bill in South Africa another dream deferred? In my concluding remarks, I'm asking who's waiting to receive care in South Africa, and using Judith Butler's concept of grievable and ungrievable lives. Judith Butler talks to us about the idea that certain systematic settler colonial projects as we're seeing in Gaza, slavery, racism, homophobia, gender-based violence, gender discrimination, patriarchy, all of these systems have a particular political frame in which they frame certain life as worthy of being grievable. And what we mean by grievable is that when a life is lost, when somebody dies, that life is being mourned. And here we're not talking about just the subjective, personal grievability when you lose a loved one, but a political, social grievability that when certain groups of people die from diseases and pandemic, their deaths do not matter in the global structure. And grievability reminds us that just in its own ontological stance that all lives are vulnerable. Lives are vulnerable to accidents, to diseases, and COVID taught us that. However, certain lives in this political structure, in the South African socio-economic landscape, certain lives remain to be protected from vulnerability by wealth, which often shields them from poverty, access to healthcare system that protects them from diseases, death, political government structures that may or not shield them from harm. On the other hand, ungrievable lives are deemed as subhuman. They remain in the veil of what Fanon calls the wretched of the earth, or the zones of non-being. As a result, ungrievable lives are considered easily disposable. What we see currently in Democracy Now! In Al Jazeera, the lives of Arab and Muslim babies being torn apart publicly, a genocide that is being televised. And so ungrievable lives, lives that are not worthy, that when their death happens, nothing moves, no global policy or certain kind of like ceasefire matters. And the question is, are we maybe in South Africa as Black majority who remain dispossessed and marginalized in this particular moment by poverty, all sorts of inequalities, in a silent genocide, which is a continuation of the settler colonial movement of the British and the Dutch? Labeling lives as subhuman for Judith Butler does not necessarily mean that they lack the moral authority to be worth it or to be much more grievable. They are. It's, however, these intersecting systems of oppression that renders them useless. And often they are gendered, they are racialized, they are nationalized, they're class-based. And so the bodies and souls of ungrievable lives are intentionally and systematically left unprotected from harm. And often, in the veil of being subhuman, these lives, which remain to be Black and colored and Indian populations of this country, few poor whites, they lack employment, adequate housing, safe schools. So it's not only the issue of healthcare, it's all of these intersecting issues on universal coverage. And again, here in sub-city, ungrievable lives are exposed to deteriorating public infrastructure, crime, and those who attempt to escape may not even survive. And so, who's waiting to receive care in South Africa? Are their lives grievable or ungrievable? What historical or social, political, and economic fabric protects or negates these lives? And I argue the two healthcare system tied system in South Africa, the grievable lives remains to be white or those Black people who can afford, protected by the private healthcare system, of course, and ungrievable lives of Black and colored communities, Indians, some, whose precarity is unprotected in the public health sector, subjected again beyond lack of quality healthcare services, land dispossession, squatter camps, spilling sewage in the street, and unemployment. And so when the public's response, and this is my ending point, and so when the public's response to South Africa's pursuit of universal health coverage, and the people respond says, we're not ready for the NHI bill, or we're not ready for universal health care coverage, it becomes evident to me that in this settler colonial state is not prepared to uplift the lives of Black people, majority, Indians, coloreds, from the colonial veil of being subhuman. When people ask that the Nyaupe boys, so are they going to join us into medical private health care system? It then reminds me that there are certain lives that are deemed worthy of being protected in this healthcare system. And what is it that it is in the waiting of receiving care? Waiting to receive care in this country means that tonight, Nikiwe will give birth on the floor of a public hospital without any medical assistance. Struggling from the wounds of vaginal birth and heavy lactating breasts, she will go around borrowing 4,000 from Mashonisa because no one really ensures a dead baby. And so Makulu's Trisana has only 1 week left to enjoy walking with her cows in the rural areas, as she was recently diagnosed with stage cancer 4. And on the day of her burial, the king will remain thus that if there were hospitals in this village, Mam Trisana's life would have been saved. At this evening, Silindilo, without medical aid protection, will bleed into death from stab wounds before the ambulance arrives in the township. Again, while the government is negotiating the universal healthcare coverage, the cancer metastasizes for the majority. The kidney fails for the majority. The liver deteriorates for the majority. And another death certificate is filed and stamped. However, as Tindai Sitole and Hugo Kahneman reminds us, we who inhabit this body as Black people, we've known what death is for so long. We've known what a collective grief, the violence of collective everyday grief. And so, as we remain waiting for the NHI bill or any form of universal health coverage, we'll continue to sing the hymns at the funeral Saturday and hoping that another will not demise and leave us on this other side. Thank you.
Thank you so much, Dr. Onwe, for your insightful presentation with South Africa achieving universal health coverage through the national health insurance. From what I have gathered with this presentation is that, universal health coverage is there to readdress the injustices of the past, and the national health insurance policy being used as a vehicle in South Africa in achieving that, especially with our public health policies or our health policies having previously been racialized. You touched on 2 points. The first was during the Gluckman Commission of how Black population, majority of people of color were excluded from these welfare systems, and also as well as the National Health Service Commission of 1942 to 1944. However, in that, we find that the African National Congress, once it had gotten into power, the key focus was in achieving welfare system for all, including Black South African, colored, Indians, and whites, right? And in December, 16th of December in 2007, the National Health Insurance Policy was adopted. But we only see 17 years that we have been waiting for the national health system to be adopted by the parliament. But in that conversation, the large majority of the people of South Africa are excluded. You touched on the points where key stakeholders in the conversations of designing this policy, mainly of the private sector, which is formulated by majority white, and those who have a key interest in the national health policy, especially when it came to the division of the budget of the NHI or the health policy sector in various provinces. I think my question now moves into, is this general public of South Africa, when we look at who are the beneficiaries of this national health policy, who are we designing these policies for? What are we redressing injustices? Are they included in these conversations? How has the government gone about it in the national sector in ensuring that there is civic participation, in ensuring that there is public education, that we are creating inputs in these policies that are yet to be implemented? South Africa is noted as a state that has great policy, but when it comes to policy implementations, we lack in that. And yeah, looking forward to that feedback.
Thank you, Tessa. Thank you. And thank you to our speaker, Dr. Sivu Isiwe. That was a very powerful talk and very insightful conversation. And I want to actually acknowledge that today we have one of my very precious mentor, Dr. Zacharias, who is joining us today. He is the Principal Director of Multipod Mentoring Program for Young Professionals and Students in Global Health. I would like to invite Dr. Zacharias, if you would like to say a few words of reflection, because I feel like, you worked in so many different countries for the past decades. I wonder what you would like to share with us today. Thank you.
Okay. First, my reaction and my thanks to everybody. This was a very informative, shocking to a certain point, inspiring, stimulating presentation. Thank you very much. The only thing I know about South Africa is about apartheid and everything that happened with Mandela, Mr. Mandela. And I was in Durban, but it was about 30 years ago, 25 years ago, for an AIDS meeting. And one of the things that really shocked me was the great difference between the Black population and the white population. Whereas at the University of Durban, people were talking about how little of a problem they had and about the sexual behavior of the white population versus the Black population. Look at that, the racial discrimination. The racial discrimination. One of the things that really I found shocking is that at that time, 50% of women coming to maternal centers were infected with HIV. And on the other side, the other part. And I was just reading a little bit about the health systems and the main health problems or issues in South Africa. And I see that HIV and tuberculosis are really important. So I don't want to take much of your time, but the thing that I found really stimulating was what to do next. Because I have been to about 60 countries, not in Africa, but mostly in Latin America and the Caribbean, and a few in Europe. And one of the issues that people find all the time is the lack of political support. And more than political support is the enforcement of the policies and the laws that they have. The second one is finance. The third one is the lack of resources. both supplies and human resources. And then as far as patients, one of the problems we faced in Latin America was transportation, accessibility, and more than anything else, the acceptability, being able to have something that is culturally acceptable for people. And one of the issues, I went to medical school in the 60s. So you can see that I'm not even 60 or 70, I'm 80 years old. One of the issues were in my own countries that people did not have access to health services. And I found a book at that time called Where There's No Doctor by David Warner. And probably you know that, in which the community developed some expertise with information as to what to do in those circumstances. I don't know enough about Africa, but to me, it's an issue of power more than anything else. It's not an issue of medical supplies or lack of infrastructure or anything. It's an issue of power. And the same way that you finish apartheid, 20 years ago or whatever, there are many things that remain. And the community and people have to take, more power by themselves. Because I have not been in any country where there are no resources at the community level. Even if they're very poor, you have your intellect, you have your drive, etc. And I don't know what will happen in South Africa, but with people like you, people with a coalition, young people that come with ideas, etc., and more than anything that can become leaders and make people who are already leaders, not only intellectually and academically, but also on the field. Well, I don't want to take too much time, but I think it was a wonderful, wonderful experience to listen to you. And you are so committed. And it's not the words and it's not the presentation. It's what I can see in all of you. It's really, really amazing, really amazing. So, and I would like to continue this dialogue. We are a few people here, so perhaps we can talk. I would like to learn more about what you are doing. I know there's a Bertha Center at the University of Cape Town, so get people from the business, community, etc. New ideas are needed because the politicians are not going to respond unless there's a movement. And I think that's her specialty and is your specialty, to get people moving. Sorry, I need to leave now so that they're after me, but I really want to thank you for this excellent, excellent, excellent presentation. I think if you recorded that, it should go to many, many people. Thank you very much. Thank you, Charlie, for the invitation.
Thank you, Dizzy.
Okay.
See you next time. Bye-bye. Yes.
Care.
Back to you, Tessa, and then Tessa is
Okay.
the moderator. Thank you.
So we'll open with the reflections to Dr. Sivuisi with from Dr. Sakura and myself into hearing more about this. Thank you.
Okay, maybe we can take 2 more questions, then I can kind of like have this first round and then we can move on to a second. Yeah, maybe I can have more questions and then I can answer them. Yeah, maybe 2 more or 3. Yeah.
So we have a question from Akira Mudise asking, what does the NHI mean for people in rural areas in South Africa, and how will it impact their lives? That is our third question. And I think from my end, the fourth question is, what does it mean? You touched on this. What does it mean with the national health insurance now that we as South Africa are in the GNU with the Democratic Alliance? We have 2 different political parties that have various different mandates. One is focused on privatization and the other is focused on achieving social welfare reform. And how does this then mean in the implementation of this policy in moving forward? And what are the possible challenges or the setbacks of this policy? Thank you.
Okay, let me address these, and then we can have we can open it up to the people on the chat. I can also, if people want to unmute and have comments, you know, we can. But let me do this. Okay, so let me start with Dr. Zacharia's comment on the people's organizing. And I think it becomes very interesting because if you look at other countries such as in Asian countries and in few countries in the continent as well. I mean, we can talk about Ghana's national health insurance. We can also talk about you know, the Kenyan system and all of that. It's very interesting that if you're looking at the historical design of universal health coverage itself, it was actually from the ground up. So it was people within communities who said, just like we share different crops when it's a harvest system, when it's a harvest season, if I've got more cabbages and then you've got more grapes, so the concept is it's old as time, that if I've got more grapes and then you've got more cabbages, depending on the system, and you've got whatever, let us interchange so that we can have a variety. And I think the concept, mostly in terms of before it was adopted into to be a national health system, it began with the community, and I do think that it does even more so remain with the community in terms of people saying that this is my contribution because I'm earning this much and this is my contribution. And my contribution is not only for my household when my child is sick, but it's for my next door neighbor. And I think the very principle of that becomes very important. I mean, for me, I come from a very small town called Plettenberg Bay, and our councillor here from my community is here as well, Councillor Samkele Manglaba. I come from a very small town where the sharing is kind of like a norm. The issue of the city, of the distance is not, and I think it becomes very important in terms of healthcare organizing. And I pray, Dr. Zakaria, that this is something that as we also think about who's going to provide healthcare services in our community, who's going to be able to the government, who the government is going to buy these healthcare services from. And this is what I've been saying, young people in South Africa, you need to start thinking about how we as young people can start our own community pharmacies that the government is going to contract. How can we start our own mobile clinics that the government is going to, and we as a community, we're going to own it, because then we'll be able to make those service providers that who are part of this community or whom we owe accountable when the services are not quality. So I really appreciate that community-orientated aspect of that. And I mean the classic of where there are no hospitals. And even if you look at Paul Farmer's long work in mostly in our continent, whereby in an era whereby people had no ARVs and the hospitals were much more overburdened, how the community stepped up to collect certain money for people to get ARVs. So that kind of community building and community is very important, and I hope that it's something that the South African government can think through as it crafts what universal health coverage in this country should look like. Rural areas. The main fundamental issue in rural areas is the lack of infrastructure. And I do hope that with the NHI fund that a lot of that infrastructure will be able to be built in the rural areas. I mean, for some of us who have traveled, you know, you'd even go to a rural area in the US, there's at least the basic electricity or a basic road that takes you to one point to another. So I think in the rural areas, unlike the urban areas whereby the politics are about who's going to be contracted, who's going to get Is it Medicare? I mean, is it Mediclinic? Is it Bara Hospital? So the politics here are about how we're going to refurbish the existing infrastructure, how we're going to make it better. But the rural area poses a significant challenge for the NHI, where you don't even have efficient hospital or clinics to contract to be service providers either way. And so I hope that this policy's move towards that is the way also the government to say that if there are no infrastructure, then you can't even have this policy. So I think there's going to have, and the policy does, the bill does say that there's going to be a period whereby the South African government focuses on building this infrastructure. And again, we hope that the promise will come. Back on the DA and ANC coalition, countries globally are moving towards coalition politics. And as we've seen in the local government election, coalition politics are highly contested, and sometimes countries spend a lot of time within the contestations of power, within one kingmaker moving from here and the other, right? And I do pray that even if the national health insurance is something that the government of national unity or future political power will not aspire to, that the commitment to universal health coverage remains. Remember, NHI is just one way of achieving universal health coverage. So I have hope that even if the NHI die as a dream in terms of what it is, or it becomes negotiated, is that the commitment with our leaders becomes very important in moving towards that. But again, to Dr. Zakaria's point, to also think through in our own communities, what are the ways in which we want to get out of the medical aid system and establish our own funds in communities? We are doing it with the Stokvel, right? The women's Stokvel. We are doing it with the funeral covers, where we got out of your AVBOP and we made our own public kind of finances so that when crises come, we are able to. And maybe that's something communities can think beyond waiting for the state to intervene. So that's kind of my my thinking around that. I think I'll welcome more comments and questions. Yeah.
Thank you, Dr. Sivu Isive. I just heard echo, but now it's good. So actually, there is another question here in the chat box from Simba. The question is, could you please elaborate on the National Health Fund and how the board members are selected, if you know?
Okay.
And I have a question. Yeah.
Let's have 4 questions and then I'll answer. Yeah.
Okay, so my question is, I think in many countries, the general public might not know the benefits of universal health coverage. Because I think when people are struggling with finances and access to things, they just made to a certain point, then they feel like if the government is providing such services for everyone, then it's taking away their money as well, right? So how do we include the general public in the conversation, and to hopefully encourage people to understand this better? And obviously, we cannot count on the media, for example. Then how do we mobilize? How do we, what are the obstacles and bottlenecks? What do you think could be the solution, or what is within our power to do? And I want to open the floor if we have more questions for our speaker. And afterwards, maybe quickly we could share how does universal health coverage look like in our own countries, if we still have time, if whoever wants to share, and also what are the obstacles in your own country. So yeah, please feel free to unmute yourself or raise your hand. I think maybe we only have these 2 questions for now.
Okay, maybe people are still thinking about their questions. That's okay. So in South Africa, boards are very important. We've got the school governing body, which kind of like each school has a representative from the community, which forms part of the board. We have the ESCOM boards, we have the public broadcaster board. So board is not a new thing in South Africa. Each and every entity that exists in this country, both publicly and privately, has a board, right? And there are certain ways in which we select board. So for example, I'll take an example of a community clinic. In terms of a community clinic, how we select board. The board members of the community clinic as well, the councillor of that particular community needs to be the representative there. Certain kind of like a representative of a particular political party will have, because they represent the people, right? We also have the volunteers of community members that would want to be part of that. And at times, of course, because it has to be a clinic run, we've got healthcare workers, that work there. So it becomes different kind of stakeholders. Now, with the NHI bill's proposal of the board, it proposes quite much more similar approach into it, that each, for example, if we've got 9 provinces, so within each province we have to have a representative on the NHI board. We've got what we call our medical associations and all of that. Those medical associations will have to be, right? And then we have also our political representatives, such as your MEC of health, depending on where you are. So it represents a particular diversity, because the fund has to be governed by the government, but the government is, in South African terms, in our constitution, is the representative. So that's how the board looks like. However, there are contestations around the board, because, for example, in South Africa, when we, like, for example, there's always advertisement that we advertise people to apply to be part of the board for SABC, for example, or we advertise for people to be part of whatever and whatever. And part of the people that are opposing the NHI, in terms of that it will report to the board, they're saying that most of the time the selection or electing people into this board is not much more neutral. It's also politically driven, right? So how is it that the government is going to ensure that everyone is fully presented into that board? So those are some of the contestations. So I've just given you an example of how an ideal, what usually the board is from. It needs to be the representative of the people, particular people that are involved in that sector, such as your healthcare workers, associations of healthcare workers, people representative of province, certain politicians from certain political parties. Do you get what I mean? Even now, we just had the judiciary kind of like employing certain judges. You saw in this committee that EFF was there, ANC was there, MK was there, from the selection of those. So there's a particular way in which you ensure that there's a bit of representation, but then even that is kind of contested. Charlie, what was your question?
My question is, so the general public might not understand why universal health coverage is important. Yeah, so what shall we do?
So, and this is what I usually say to young people. I usually say that never underestimate your parents, never underestimate your grandparents. What you think is new under the sun is old as 1800, right? It is not the fact that the people don't understand what universal health coverage is in South Africa. They do. And the principle, when you ask somebody about the NHI, what the NHI is, they might not give you the technical terms of we're going to pool fund, we're going to do this, but they will tell you that the government will provide all of us. They even say all of us will have medical aid. They understand even the most, what you deem to be the most illiterate person, understand that there is an obligation as a citizen and as a citizenship right that you should get a particular dignity and protection when you are a particular citizen or a resident of a country. And they know what it is. They might not have the bougie technical terms of policy language, but they understand that as things are not working. The general public's concern in South Africa is that how the financing is going to be, right? But the poorest of the poor, who's never walked into a private healthcare hospital before, they don't even care if they go into a private or public hospital. They just want, when they go to a public hospital, they want the services to be good quality. All right, so the people do know. It's just the technicalities then of the policy documents and whatever, which at times, because for example, if you say to people in my township, let's do a collective saving, which you know as umgalelo, as stokvel, so that when Christmas comes, we're not hungry in our household, they'll contribute throughout the year. So they know what it means to contribute and collective saving, which is an essential principle of every insurance. They know what collective saving for umasingcwabane, which is the localized funeral cover, because they're understanding that death is imminent and it can come to your house. They understand that, right? And I think that the South African government's task is not to say we're going to educate people because people are illiterate. That's not their task. The people know what collective savings is. The people are just concerned about the how. How is it going to work if you take my 500 Rand every month? How are you going to ensure that I'm going to get the healthcare services? Because as things are right now, I'm not happy about 1, 2, and 3. So I think that is the public education that is required to take people with you, with your plan on the how, but not to say that even my grandmother was in the rural areas, who never had a high school education, know what collective saving is. So I think the task is not really, and then of course now the policy is going to be politicized because South Africa has entered into different politics, and politicians are gonna, sometimes gonna do all sorts of things in terms of changing the narrative, but people do know what collective saving is. So I don't think that's the task is an illiterate task, but the task is the how. If you take my money, how are you going to ensure that I'm going to get the services that I need? And most people are not worried about contributing. The poorest of the poor in this country, and I always say, even to the people that say NHI is going to take my tax, and I say the poorest of the poor in this country are paying tax through value-added tax, which is the product. If a person buys bread, they're paying tax. So you're not the only one that pays tax. So I don't think it's an issue that the people are illiterate, but it's an issue of the how. Yeah. And there's big work that needs to be done around that.
Thank you so much, Doctor. I want to ask if Mutile wants to speak for 1 minute quickly about the new social health insurance fund in Kenya. Mutile, would you like to?
Sure, I'll give it a try. Thank you so much, Dr. Siwe, for your incredible insights. I've just really enjoyed learning about even the concept of ungrievable lives. That was really interesting. So in Kenya, the government has recently rolled out this social health insurance fund, and there's massive public outcry about it because people are not seeing the benefits of it. They've increased the tariffs. in a very economically unstable situation already, and the benefits have seriously decreased. So people with chronic illnesses, diabetes, hypertension, even over the past few months, there's just been a huge issue with people not being able to access healthcare with this supposed better reformed healthcare, plan. So sometimes the approach of the government is to say that this has been miscommunicated. You don't understand what we're doing. And I find that very belittling and unfair to the people, because they understand how money works and they understand the value that they should be getting from public health. So yeah, I just wanted to kind of reflect on what you've said and see the similarities where governments sometimes impose policies that do not really benefit people and then claim that the people are illiterate and not able to understand the good of this system. Yeah, so just thank you for those thoughts.
Thank you, Mutile. Dr. Sibui Siwe, would you like to have a word of closing for today's webinar? Thank you.
Okay, let me go to Mutile. And Mutile, again, as remember when I said to you that there's universal health system don't live in isolation. They live in a highly political, contested time and era. And I think for us who've been in the healthcare system throughout the years, we've seen even how the AIDS pandemic was politicized, not only in South Africa, but globally, but also how the AIDS pandemic was monetized, how the activists who remain at the forefront of the struggle in the United States of America, but also in South Africa and in the continent. So I always say to my students that health is political. Health is politicized. And I think what's happening to Kenya should not be read into isolation. It was happening in post-independence, whereby our government gets into hectic loans with the IMF, and we saw now, hopefully, we're hopeful about the BRICS as South Africa, that the BRICS nation, we'll see how it goes. I'm always hopeful about certain things, but then we'll see how that goes, in which we have a much more the powers of the world. But Kenya's also needs to be located within the heavy loans of the IMF. So I always tell people, when you take money from the IMF, the first thing that they do, they say you need to cut out on public spending, you need to cut out on health, you need to cut out on education. That money comes with T's and C's. And then most African leaders still battle with that, because although you need money for the development of the infrastructure and all sorts of things you need to achieve in the country, but also you have to bow down to what the IMF. And I saw the Gen Zs in Kenya rising up, and may those whose lives have been lost, may they rest in peace. The struggle continues. And back again, that is exactly what the ordinary South African is saying, to say that if you do take my money, how am I going to have, an assurance that you're going to buy that which you say that you're going to buy? Because already you are taxing me and I'm not seeing the benefits of my tax money. And universal health coverage as well have their own challenges and their own system. Within the system, it's not the gold, whatever. It has its challenges, although its principle is good. And we saw with the NHS in the UK right now, long waiting lines and whatever, whereby people are waiting for 6 months to get operation. And then the US people are like, yeah, we did tell you about social medicine, because US call it social medicine because they are a whole privatized entity right there, but in which the majority can't access healthcare. And I always say to people, policies in their nature, there is no policy that is neutrally progressive, right? There are actors within particular policy that can make the policies fail or they make the policies succeed. Because it's also interesting that when you look at Kenya and how the universal health coverage started in Kenya. It's not the same as the progression and the deterioration is not the same as when your parents, they were in their younger, when they tell you about what universal health coverage looks like in Kenya, no, you're talking about two different things because they saw how it worked back then. So again, it's always to remind people that there's power, there's contestations in health policy, there's politics in health policy, there's all those contestations. And my closing remarks, there's work that needs to be done. And I'm glad that there's a coalition of global health professionals who are thinking through these things, who are really thinking through about how do we restructure post-independence in countries that have suffered through colonialism. There is work that needs to be done, but there's also the rise of the right, the rise of the fascists that we're seeing globally, the rise of capital. It has never been brutal and it has never been violent, cannibalistic as it is now. And I wish that in your own little corners, the work that you do, all of you may continue. And as you continue, you remember the children of Sudan, you remember the young men of Congo that are in the earth of the belly feeding this global capital, that you do remember the children of Gaza, that you do remember the people of Lebanon, and that you remember that although you are born in a particular country, you are a global citizen. And may we continue to rise our fists high for equality, equality for people's land, equality for water, and may we continue to rise our fists even higher for a just planet, as we can see now that the planet is really, really not happy with us. So all I can say in closing remarks that access to quality healthcare for all, but also access to freedom for all, access to land for all, access to quality water, because all of these things contribute into our well-being. And may we continue to be kinder to the planet so that it can bear those kind fruits to us. Again, to the people of Lebanon and the people of Gaza, we are with you, and thank you.
Thank you so much, Dr. Sibu Isiwe, and thank you so much, Tessa. Thank you everyone for joining us today. I'd like to encourage all of us to think when we talk about certain policies or certain rights, who is not at the discussion table? Whose interests and rights are being ignored? So let's look around us, in our own communities. There are people who are struggling, and why they are not taken into consideration, and why are we not caring for them? Don't we have this collective responsibility to take care of each other as well? So since we're young professionals in global health, I think there's a reason why we chose to be in this field. So I hope that we keep the conversations going, and I think in our upcoming community calls, we'll talk more about the universal health coverage in all of our countries and share knowledge and mobilize, and let's keep this conversation going. So thank you everyone for joining us today. I wish you a nice evening or the rest of the day from wherever you are, and we will be having more meaningful conversations. And please feel free to reach out to myself and Yelena and whoever here. Connect on LinkedIn, stay in touch. And if you would like to talk about some important topics, please let us know. So thank you, and see you soon. Bye. Bye, everyone.
Goodbye.